I'm going to say a little bit about why I think that this new perspective is necessary. Nancy's already said a few things about that. I'm going to say what the AIDS transition is as I conceive of it, and I'm going to say how I think we can accelerate the move to the AIDS transition. Now, most of you know that this year the AIDS epidemic is officially 30 years old, and you know it's still growing, with 33 million people infected with HIV, 16 million people needing treatment by WHO's current definition of need, of whom only 5 or 6 million people are receiving that treatment in the developing world. So this is a big problem, and we also know that funding is not unlimited. So Nancy referred to the extraordinary increase in funding that occurred between 1997, the establishment of UNAIDS, and the year 2008. The rate of growth was actually 28% a year, and for over a decade. I'm not aware of any other type of foreign assistance or even category of expenditure that has grown for 28% a year for a decade. Think how fast that is, 28% a year. That means doubling every 2.5 years. The epidemic is 30 years old now, and we can project that it's going to continue decades into the future. In 25 years, a rate of growth of 28% a year would take $13 billion to equal 15 trillion. That's the size of the US debt. So 28% a year really, really was not sustainable. And sure enough, as we know, when the 2008 financial crisis hit, and even before, in the PEPFAR reauthorization bill of 2008, President Bush programmed a change of course for that rate of growth. He already programmed in a flattening of the program of the US government's expenditure. This graph shows what happened to US government's expenditure from 2008 on to 2011, the way it flattened out. The top line is total spending, which is still under $6 billion. And the red line is an approximation of what portion of that is being spent on AIDS treatment. So with only a third of the people who need treatment receiving it, even after all these years of really exceptional effort, we have to recognize that we're going to need to have a new perspective if we're going to try to attempt to meet this epidemic and continue to make progress, not give up, but at the same time do so within what is certain to be a less explosively growing budget, possibly a flat budget. So the idea of the AIDS transition is depicted in this diagram. What we're calling for here is something that really is basically very simple. The red line represents the number of AIDS deaths per year, and the green line the number of new infections per year. And what we're calling for in the AIDS transition is explicit planning by donors and by recipient governments for the new infections per year to be pushed down below mortality. So we want to hold mortality down while pushing new infections even lower. Where does this idea come from? Well, in my case, I was inspired by my knowledge of an historical phenomenon that is called the demographic transition. The demographic transition is a classic story from development of Europe, and then more recently of many developing countries. Here you can see the birth rate of a typical European country in pre-modern times in stage 1 on the left of the graph. The birth rate is in blue. It fluctuates from year to year, but it was quite high at 40 per thousand per year. The death rate also was equally high, and that's in red. So when both were high, the population did not grow. It was quite stable at a small level. But then with urbanization and industrialization, as public health methods began to spread in the society, we saw death rates fall dramatically, as you see the red line dropping down. And as death rates fell, but birth rates remained high, the population started to grow rapidly. And the population grew until stage 3, which you see here is labeled as mature industrial. And in stage 3, the birth rate then began to fall. until in stage 4, in some countries, it's actually now below the death rate and the populations are shrinking. The black line shows on the right axis the total number of people. You can see that it's flat when both rates were high. It's growing rapidly when the rate of birth was much higher than the rate of death, and then it flattens out again. So the transition refers to a change from a situation where both rates are very high to a situation where both rates are very low. And what I'm suggesting here is an analogy with the AIDS situation today. Deaths from AIDS in all regions of the world have been falling, and they've been falling thanks to the very rapid and successful expansion of access to antiretroviral treatment. The lower line in each of these graphs that comes from UNAIDS represents what actual deaths have been in each of these 4 regions, while the upper line represents what deaths would have been in the absence of treatment. And you can see that that divergence began early in Latin America because the Latin American countries were middle income and they had the resources to begin to pay for AIDS treatment even when it was very expensive. The divergence happened much later in sub-Saharan Africa and in fact coincided with the really dramatic expansion in 2003 of US support for AIDS treatment and the PEPFAR program. But while the deaths have been dropping rather rapidly, the new infections, which is analogous to the births in the demographic transition, the number of new infections has been declining much more moderately. You see a slightly different pattern in each of the 4 regions here, with peaks in the epidemic in Asia, for example, in 1996, a less marked peak in Africa in 1997, a very pronounced peak in Eastern Europe and Central Asia in 2002. The annual number of infections peaked in all of these regions in those years. In Latin America, it's less clear that there was a peak. We even seem to see a relatively stable situation there. But the most important of these regions in terms of numbers of infections is clearly sub-Saharan Africa, where there has been a constant rate of decline of about 2% per year since 1997. If we look only at the 18 countries where the US government has been most active, the countries where PEPFAR has very rapidly expanded treatment, what we see is that death rates have fallen since 2005 at an annual rate of 5.6% a year. And that's in comparison to new infections, which have also fallen, but at the much smaller rate of 1.8% per year. So that the pattern is very similar to the one we see at the beginning of this transition. AIDS deaths are falling now because of the access to treatment. New infections have not yet fallen as fast as they need to in order to get us to the AIDS transition. The AIDS transition, that is the point where new infections fall below deaths, is the point when we really begin to turn around this epidemic in the sense that the burden of people living with HIV/AIDS who need annual support for their treatment begins to finally fall. And we know that Secretary Clinton and UNAIDS have expressed a eloquent vision of a world without AIDS. I want to submit to you that unless we can get to this point where the total number of people living with HIV/AIDS begins to fall, we won't get to a world without AIDS. This is a necessary stepping stone, a milestone, if you will, on the road to that world without AIDS. So some people have responded to this idea by asking me, why are you comparing new infections to mortality? Why not compare it to a much more optimistic sounding thing, which is the enrollment of people on treatment? Well, there are 3 reasons why I think, although that's an important comparison, it's not the most basic one. First of all, making that comparison in a simple way would ignore the fact that low quality treatment, in fact, does not sustain the reduction in mortality. Our objective is to keep mortality down, and that requires enrollment in high quality treatment. Enrollment in high quality treatment will achieve one of the 2 goals of the AIDS transition, which is to keep mortality down. But it also expands the fiscal and the dependency burdens. And therefore, I'm arguing that we need to define the AIDS transition as the point where new infections is pushed down below the rate of AIDS deaths. This objective will unite into one objective the twin goals of suppressing AIDS mortality and reducing the overall burden. So I've talked a little bit about what the AIDS transition is. Now, in a way, it's just arithmetic. I think what's useful about the AIDS transition is that it does form an intermediate goal, but I'm going to argue that there are two things here that we can do to accelerate the AIDS transition, and both have to do with aligning incentives properly between the donor and the recipient and within the recipient country. So the first thing I want to describe is a suggestion for reframing the partnership between the donor and recipient. And for our representative from South Africa, I want to suggest that this discussion could also apply to the relationship between a federal government and a provincial government. So that's the first part of the how. The second part of the how has to do with applying this approach to foreign assistance that Nancy has talked about in her opening remarks, the cash on delivery approach, in which we pay a symbolic amount for every averted HIV infection. So first, let's think about the relationship between the donor and the recipient as it now stands. As it now stands, of course, and this is true not only for HIV, but it's true for in every domain of the U.S. bilateral assistance programs and of the bilateral assistance programs of every country. The donor is free to move resources among recipient countries from one year to the next. It can shut down programs, it can start up programs, and we know that it frequently does so, and that recipient governments are frequently suffering from really total uncertainty about what they will receive from donors in the next year or two. Because of the fact that the donor is free to manipulate resources in that way, the recipient government is unsure if its contributions to that same objective, in our case AIDS treatment, will be in fact offset by reductions from the donor. So who gets the benefit when there are efficiency improvements, when there are reductions in the price at which antiretrovirals are purchased in country, when there are reductions in the improvements in the efficiency with which services are delivered, reductions in cost? Well, clearly the recipient government and the citizens get the health benefits, but the fiscal benefits go entirely to the donor in this scenario. So what we're arguing here is that instead of this status quo relationship, there should instead be a multi-year commitment between the donor and the recipient government. This is something that's difficult for the U.S. to do because of constitutional constraints, but we know from Hillary Clinton's speech that the U.S. is already making multi-year commitments to the Global Fund. Those have to be informal commitments between the administration, which must be promising to attempt to ask Congress for that money. Nevertheless, if the U.S. can make such a multi-year commitment to the Global Fund, it could also make one to Nigeria or Burkina Faso or Mozambique. And what we're suggesting is the donor make a multi-year commitment until the date of the AIDS transition, as it's projected to be by the best models, and that the commitment be for the percentage of treatment need that the donor feels it's willing to provide. Now, if that percentage were always 100%, I would not be here. We would be living in a world where resources were not scarce. But I want to suggest to you that it's unlikely to exceed 70% in any country, and in many countries it will be more like 30%. But whatever the donor is willing to finance in terms of the total treatment need, whatever percentage, it should agree to up front for the period required. It might be 5 years until the projected date of the AIDS transition, or it might be 10, or it might be 15. But that means committing to that stream of resources for treatment throughout that entire period until the AIDS transition is projected to arrive. Once that the donor has made a credible commitment of that sort, the recipient's in a much different position. It knows that its contributions will not be offset by donor subtractions, that every contribution it makes will in fact contribute to the health of its own citizens. And it also knows, suppose it decides to add to the 30% that comes from PEPFAR an additional 5%. It knows that 5 out of the 35, what's that, 1/7, of all the efficiency gains in that program will accrue to the recipient government. So it gets its share of the efficiency gains, the financial efficiency gains as well. So this is the thing I think that the transition idea offers. It offers this possibility for what I would describe as an incentive-compatible contract where the donor country, or in the case of South Africa, the provincial government, would in fact have the fiscal as well as the health-related incentives to improve the efficiency of its own program. But then once this is in place, there can also be an understanding that everyone hopes to be happily surprised. Everyone hopes that the rate of new infections will fall even faster than in this projection that we've used to compute the date of the AIDS transition. And if they do, that means the donor is going to save a lot of money. It won't save that money immediately, but if we project forward a faster decline in new infections, it means that in the year 2030, 2040, in the out years of this projection, there will be fewer people to treat. And that 30% that was committed will be 30% of a smaller number. So this means that the donor can be in a situation, even right at the beginning, to offer to the country that faster decline in new infections than has been projected can be rewarded by increasing the generosity of the donor's commitment to treatment. Take it from 30% up to 35 or 40%, depending on the magnitude of the prevention improvement. So this is, I think, a proposal for a way that the donor could relate to the recipient governments, which would improve the incentives for prevention and also integrate prevention and treatment. Now, I want to be absolutely clear that I'm not prejudging how the prevention should be done. One way that new infections can be reduced much more effectively is by appropriately targeting treatment so that it has the best prevention effect. We know from HPTN 052 that in a serodiscordant couple, if the HIV positive partner is treated and treated effectively, that the chance of transmission to his uninfected partner is reduced by 96%. So I'm arguing that that can be very definitely one of the means by which the government might do much better on reducing the rate of new infections than the model would initially project them to be able to do. But there are many other ways that the government and that the citizens of the country might improve upon prevention. So that's where I come to cash on delivery. Cash on delivery is not a technical idea. It's an idea about changing the incentives. We know that the great success stories in HIV, whether we look at early years in Uganda or Thailand or in other countries where there have been partial or really fairly substantial successes in HIV prevention, I can't think of a case where national leadership and political leadership, a political willingness to address HIV prevention as a problem that the entire society must confront together, I can't think of a place where that has not been present. So what we want to do with this COD approach is to essentially leverage that type of leadership within the countries suffering the most from HIV. So these 5 key features of COD apply to it in every application, whether it be to education or to health or to road building for that matter. In the case of I'll speak specifically about HIV. The first and most important point is that this is a very extreme form of results-based financing. We want to reward only improvements, and in this case it would be HIV infections averted. Hands off, meaning that at least as part of this COD agreement, the donor does not ask how it's done, does not give advice about how it should be done. The responsibility for figuring out how to do it is entirely that of the recipient. The verification must be independent because it has to be the case that these infections are truly averted and that it's not just statistical legerdemain. Transparency is important not just because of the verification point, but we believe that in a country where the success or failure of local HIV prevention programs was transparently disclosed to the public on a regular basis, as we would require as part of this program, we believe that in such a country, governance will improve, the support for HIV prevention will improve, and that it will generally be a positive thing, not only for the HIV prevention effort, but for the country as a whole, and the sense of accountability within the health sector. And lastly, we're not suggesting that this cash on delivery reward replace input financing as it currently occurs. We don't believe that that is possible immediately. Maybe it could be possible in a very long run. But what we're suggesting is that the reward per HIV infection averted be a relatively token sum, that would perhaps exceed in total a maximum of not more than 5% of total HIV prevention funding from donors in that country. It's important to think about, in the context of any results-based financing scheme, we want to avoid unintended consequences. And there are two classes of unintended consequences to which we would have to attend closely, and we would have to build attention to these possibilities into the original contract at the time that it's signed between the donor and the recipient. The first is we have to be sure through the independent verification mechanism that the measurement of HIV infections averted is not biased. And we do that not only by having a third party do the measurement, but by having a fourth party audit that measurement. And then it's also really essential, especially in the case of HIV, where stigma has been a problem, that we assure that the mechanisms that are used, that are developed independently by the people in order to try to achieve this, this cash on delivery reward, that those mechanisms meet the criteria for ethical conduct. That we want to assure through the frequent administration and implementation of social audits, such as the World Bank does in other cases, that human rights are not infringed in this process. So if it works, cash on delivery for HIV will elicit the local use of the best HIV prevention ideas. This is an important reason why I think it's a necessary ingredient in HIV prevention. There are ideas about HIV prevention which simply are not national or international. They are local ideas. They have to do with the local authorities, local traditional authorities, and changing of social norms within very local societies. What we're hoping is that by having this cash on delivery approach at the top for the government, that the government will invent ways to cascade that set of rewards down to the local level where innovation is really necessary if we're going to see a big change in HIV infections. So if that works, then we'll see rapid reductions of HIV incidence. We'll get more quickly to the AIDS transition, which will put universal access within reach, and we'll do all of that without unintended consequences. So these are the two main themes in the book, and I very much look forward to the discussion from our four panelists of these ideas, and as I said, any others they have on their mind.